The broadcast is now starting. All attendees are in listen-only mode.
Sing a song, sing out loud, sing out strong, sing of good things, not bad, sing of happy, not sad, sing a song. Make it simple to last your whole life long. Don't worry that it's not good enough for anyone else to hear. Just sing a
Good morning, everybody. That who you may know was Karen Carpenter, one of the most famous, popular, and beautiful voices of all time. And I'm Dr. Minarsik, and today is Tuesday. It's March. We're almost halfway through the month that comes in like a lion, but goes out like a lamb. So we've actually had a couple of warm days last week, but we're still generally in winter. It's March 8th, 2022, and today is our 45th webinar of the year, and it's our 5th webinar on the GI system, GI pathology. We did the entire gastrointestinal tract from mouth to anus. We did the liver. And today we're going to do the gallbladder and biliary tract and the pancreas. And you may notice that we have a new coconut coffee cup. So here we go. Let's give you some. You know, every time we do a webinar, I promise you it's not going to be too long. And you might think I've been betraying you because I said in the last two webinars that's not going to be the full 2 hours, and it went almost a full 2 hours. So, but I feel very, very strongly because neither of these are really, really long topics. I think maybe we will not have a terribly long webinar today, and I promise not to betray you again, but I might, but it's really not likely. Okay, what can we say? how about if we just put down our little camera here and we pop up our PowerPoints, and we'll be talking about the extrahepatic bile ducts and gallbladder. And I guess a good way to start is to show you a gallbladder. Probably in a way you've never seen it. You may have seen them in surgery, you may have seen them in the autopsy lab. But you know, when you take Histology 101 and they give you an example of simple columnar epithelium, they usually, or often at least, use the gallbladder as the primary example, because the columnar cells that line the internal surface or the mucosa of the gallbladder are very, very regular, okay? These are all nice columnar cells. You could count them. They're all nice. The nucleus is at the base. And then, you know, because the gallbladder contracts, it has to have some smooth muscle and connective tissue in it. And because most of the gallbladder is intraperitoneal or intra-abdominal, you'll see a nice little serosal, one flat, tiny layer of cells lining the outside. Sometimes a lot or much of the gallbladder is kind of tucked away inside that gallbladder fossa, and you don't see the serosal mesothelial lining there. So, what we'll be talking about with the gallbladder are the things that you probably figured that you've heard of before. Maybe you have not heard of some of the common anomalies. We're going to show you that. But you know that the gallbladder can have stones and your gallbladder can become inflamed. So we're going to talk about these two topics. And even though I said two topics, a lot of people think they're one, because stones are intimately related to inflammation, both acute and chronic. And inflammation is every way intimately related to stones as well. And of course, the types of stones that you get in the gallbladder are the kinds of things that you see in the gallbladder. Do you see a bile in the gallbladder? Good. So you'll see bilirubin stones. Those are either green or black. And of course, cholesterol stones are probably just as common, maybe even a little bit more. And whoops, I made a typo there, didn't I? I can't believe I had that for all those years. So you can also have stones inside of the bile ducts at various levels as well. You can have a cyst, usually acquired as a congenital anomaly, because in the foregut outpocketing to determine part of the pancreas and the liver and the gallbladder and the external and internal bile ducts, you can have cysts along the way, or you can also have blockage of those ducts as well. But gallbladder cysts are generally in kids, and they're generally related to things that may have happened before they were born. And of course, can you have a neoplasm of the gallbladder? Of course. If you have columnar cells, you can have an adenocarcinoma. Technically, if you have smooth muscle, you can have a leiomyoma or leiomyosarcoma. We're going back to our old rule again of where you see the histology, you can see the possible proliferations, both benign and malignant, of the cells that compose the organ. Could you have a mesothelioma? Okay, these little tiny, tiny flat cells which you could barely see. Yes, you probably could. I never heard of one, but of course it's possible, okay? So, I guess a good place to start out with is the anomalies. Could you have a gallbladder that's congenitally absent? Remember, this is an outpocketing of the foregut, and you don't have to have the full development of all the ducts and all of the pockets, of which the gallbladder is the biggest one. Could you have duplications of parts or of the biliary tree? Yes, you can. That's also a anomaly that is related to something congenitally as well, usually. Could you have a gallbladder that's bilobed? Now, we know that the gallbladder looks like a single large egg, but could that large egg really be kind of be divided in two, like with the septum? Or yes, you can. There's another interesting and not too uncommon condition called a pharyngean cap. Well, you're probably wondering, who are the pharyngeans? Well, we'll tell you about them in a minute. Now, like the entire GI tract or any of its branches in general, could you have a narrowing or decrease in cells or decrease in diameter of the gallbladder and or ducts that it's a part of? Yes, you can. Could you have a complete absence or agenesis? Yes, you can. So these are all possibilities, and I think they're all logical, because when you think of the embryologic development of that portion of the foregut that gives rise to part of the pancreas, the gallbladder, and the biliary tree, just imagine anything that could possibly go wrong. Could part of it not be there? Could part of it be duplicated? Or could part of it, for example, be dilated, like a cyst? So, who were the Phrygians? Well, I understand they were ancient Turks, and they lived about 1,000 years ago, and they wore caps like this. This is a guy wearing a Phrygian cap up here. It's like wearing one of these sock hats that kind of flops over. So when you think that you could have possibly a gallbladder in which the end of it flops over a little bit, you can. Here's another guy wearing a Phrygian cap. I don't think he's a Phrygian, but I guess he could have been. Who knows? I don't think they're around anymore. And here's a gallbladder. And you notice how at the tip or apex of the gallbladder, it's either kind of puckered in or folded over? Well, that's a Phrygian cap. I've seen a couple of them. That's kind of cute. It's kind of also cute to say the word Phrygian. Of course, let's talk about the common things. For example, stones. What causes gallbladder stones or cholelithiasis? Well, there's several factors. And there's also 2 or maybe even 3 different kinds of stones as well. If the bile is super saturated with cholesterol, remember the liver is the main processor of cholesterol, so you can have a lot of it generally in the biliary tree. But if for some reason it's super saturated, that would be a reason for actually plating out or generating cholesterol crystals. Now, if the bile was moving continuously like it should, gallbladder contracting with meals and so forth, even if it was super saturated with cholesterol, the bile would still flow, okay? Now, what if you had a perfectly normal internal contents of a gallbladder, but you took some of that bile from the gallbladder or the biliary tree and looked at it under a microscope, and you could see tiny cholesterol seeds or crystals? Well, that's another factor, because those little seeds can grow up into be big stones to the effect of perhaps filling up the entire gallbladder. And remember, we're talking now about gallbladder cholesterol crystals. They're generally different from the bilirubin stones. However, sometimes they are mixed together. They're often mixed together. So the general rule is cholesterol, because it's a fat, of course. Like you get a lot of cholesterol in the adrenal cortex. Cholesterol stones are generally yellow. Bile stones are the color of bile, either green or dark green or even black. When they get really, really green, they look black. Now, you're probably thinking, well, what about calcium? The most common type of stone in the urinary tract is calcium. Well, you can get calcium stones in the gallbladder, okay? But they're the least common type. They're relatively rare, okay? The most common types of stones that you get in the gallbladder bile are the things that are normally in bile, like bilirubin and cholesterol. So the general rule is calcium stones in the gallbladder are just a small percentage. I've heard 3 to 5%. But calcium stones in the urinary tract are the predominant type of stones. Okay, now I'm going to show you an interesting thing. This is a gallbladder that's been opened up. And you can see the mucosa. And the mucosa looks very, very dotted, bright yellow. Well, if it's yellow, anything yellow that you see grossly in the body is probably fat. So this type of fat is called cholesterol, okay? Now some of them they almost look like they're big lumps. You might say, hey, is that a stone? Is that a stone? Well, they're not. They're actually what you would call a cholesterol polyp, okay? Or cholesterol papilla, for example. They are connected to the mucosa. These are the same type of, this is the same type of material you might see in the atherosclerotic plaque. It's cholesterol being chewed up by macrophages. Now, these stones can break off and become free, of course, but even if they didn't, if you removed the bile from this gallbladder, even though you didn't see any stones, and you put it under the microscope, and you polarized it, you would say, oh my God, these look like beautiful, multicolored, bright crystals. These are classically what cholesterol or cholesterol ester crystals look like under the polarizing microscope, okay? And to tell you the truth, actually I always try to tell you the truth, but a lot of times a person may have symptoms of gallbladder disease, even acute gallbladder disease, and the surgeon may go in to take it out, and maybe even though they're symptomatic, they may not show any real stones at surgery or radiologically or ultrasound, but the bile is kind of thick. So the surgeon may ask the pathologist just to put the bile underneath the microscope and polarize it. And if they see that it's just loaded with these cholesterol crystals, that gallbladder comes out because it's a matter of time before the stones actually occur and may cause blockage of the ducts, which of course is the thing that causes the symptoms in acute or chronic cholecystitis. So these is called cholesterolosis of the gallbladder. Not surprisingly. Now, if you took a section through it, those bright yellow things are actually part of the mucosa. You can see a lining here of columnar cells. But in the subepithelial tissue in the mucosa, you see these foamy cells. See all those tiny little black dots? Those are macrophages. And they are just chewing up cholesterol. And this would be perhaps exactly what you would see in a soft or an atherosclerotic plaque as well. Cholesterol being chewed up by macrophages. So what you see grossly here, take a slice here, you see microscopically here. Okay, now of course, this is a gallbladder now that has been opened up in the path lab. And I'm going to ask you, what kind is it? Well, you're going to say, I see a lot of yellow, so it's cholesterol. Yeah, but what's the stuff on the inside? It's actually either black or dark green. So this is what they would call a mixed stone of both cholesterol on the outside and bilirubin on the inside. Now, pretty soon we're going to find out how this relates to symptoms and inflammation. It is going to be a very simple principle. Here's another gallbladder that's been opened, and this is an easy one. I'm going to ask you as a quiz. You could answer if you want, but it's going to be an easy answer. What do you think these stones are made of? Or what do you think these stones are made of? They look jet black, but it's really, really, really dark green. If you had a sliding scale, a digital bar showing the shades from light green all the way to black, this would be very, very close to the black portion of the scale. Okay. We talked about stones, and we give you the risk factors. We can talk about probably the single biggest risk factor, and that's cholecystitis. I'm going to make this very simple for you. Cholecystitis is inflammation of the gallbladder. It could be acute or chronic. Cholelithiasis are stones. Cholecystitis is intimately related and a causative factor, perhaps the main causative factor of cholelithiasis, and vice versa. The stones cause the inflammation, and the inflammation causes the stones. But the inflammation can be acute inflammation. If you remember, with acute inflammation, we have leukocytosis, we could have fever, we could have elevations of a whole bunch of things, elevations of the sed rate. And right upper quadrant pain, classically, sometimes it could radiate to the back. But for the most part, most of cholecystitis, in particular acute cholecystitis, is a right upper quadrant pain. Okay, chronically, you could get the pain in the same area, but it's not as intense. In fact, much of chronic cholecystitis is totally subclinical, which means the patient is asymptomatic. Of course, ultrasound can detect the stones very, very well. And there's a scan that I've done millions of times, and it's still very, very important. It's with a nuclear isotope. It's with a technetium-labeled isotope that concentrates in the bile. And if you see at some point after injection a really, really, really bright spot of activity where the bile is, in the lower portion of the liver, you know that's the gallbladder. But at some point in time, that activity should disappear because the gallbladder contracts, either normally or in association with meals or drugs. If that big bright spot in the liver is still present, it means the gallbladder can't contract. Okay? And in both acute, even more so acute, but in chronic cholecystitis, the bile is not cleared from the gallbladder. And that's what we call sluggish flow or immotility, okay? Now, cholecystitis and cholelithiasis go hand in hand together in every possible way with respect to age and sex and weight. You know, obesity, usually females a little more than males, older age, okay? And if, of course, you get it, and probably half of you will at some point of your life, if you live to be as old as me. If the surgery is required, most of it is laparoscopic now, okay? In the old days, when I was in the early part of my practice, a cholecystectomy was an open cholecystectomy, and that required like days of hospitalization. Same thing with an appendectomy, okay? Now, because most of it is done laparoscopically, the patients are out of the hospital really quick, and they don't generate a lot of charges because charges are related to LOS, or length of stay, which means the government saves a lot of money, or maybe even the patient does. Now, we said that you can also have cysts of the gallbladder, and most of them are developmental, okay? They occur during the development of the bile ducts. We're going to show you an embryologic picture pretty soon. Now, in a normal external or extra biliary duct, you have a left and a right duct, okay? And even though the left duct drains part of the right, because the right is so much bigger, you then have a single tube going ultimately then to the ampulla of Vater, and somewhere along the way, the gallbladder and cystic duct opens into it. So could you have a cyst between the opening of the cystic duct and the common bile duct? Yes, you can. You could have a large cyst. You could have a small cyst. You could have a cyst within the liver, what they call choledochal cysts, of course. You could have a couple of cysts along the way. Or you could have multiple little cysts, even microscopic. When you see a cyst in the liver that's lined with biliary type epithelium, like you see in the intrahepatic bile ducts, you can call it choledochal cysts. And they could occur anywhere, theoretically. There's like a type 1, type 2, type 3, type 4, type 5. I don't think it's so important to know what types are present, but just remember, you're looking at the full spectrum, the full anatomy of the even the intra, but also the extrahepatic bile ducts. And you could have a cystic dilatation anywhere along the way. usually congenitally, but you can also technically have them occur after a birth as well. Whoops. And finally, the last thing we always talk about, now that we talked about the benign cysts, could you have a malignant proliferation in the gallbladder or biliary tree? Well, remember in the last webinar we talked about adenocarcinoma of the intrahepatic biliary ducts. And now that same epithelium lines the gallbladder. So the same type of adenocarcinoma, the same etiologic factors that might cause a cholangiocarcinoma intrahepatically can affect the external or extrahepatic biliary ducts as well. Here's a gallbladder filled with a big tumor. Okay, and here it is microscopically. I don't know, should we blow this up for you? Yeah, I guess we can. Let's see if we can make this one bigger. No, maybe not. Would it help if we did this? Anyway, you can see that these are sort of aborted or haphazardly growing glands, impinging upon each other, an intimate relationship with the stroma or fibrous connective tissue between them. Some of them are well developed enough to have actual lumens, and some of them don't. Adenocarcinoma of the gallbladder, it's relatively rare. And I've talked to a lot of pathologists that are smarter and older and more experienced than me. And everybody I've talked to during my long career said they have seen a few adenocarcinomas of the gallbladder, but they've really never seen anybody survive one. Okay. I guess if, for example, if you found a small one, may have been asymptomatic, but the gallbladder may have been taken out for another reason, that technically would be somebody could possibly survive it. But they have a very, very dismal prognosis. Okay, so we're done with the gallbladder and biliary tree. And I told you it was not to be a long webinar. So how about if we not take our break yet, because it's not even 9:30, but let's go into some of the introductions of normal pancreas anatomy, histology, physiology. And this is what you might expect the pancreas to look like. Of course, when you were doing your autopsy or your anatomic dissections on cadavers last year, you probably never, ever, ever dissected out a pancreas that looked this nice. Most of the time you couldn't even find it because it was retroperitoneal, like most of the entire duodenum is as well. But this technically would be a good general pictorial concept of what a pancreas should like from an anterior view. Most of the sweep, the descending, the transverse, the ascending duodenum surrounds the head of the pancreas, and the head of the pancreas actually contains both parts of the dorsal and ventral buds of the pancreas embryologically, and then that pancreas kind of tapers off towards the left, paralleling the splenic artery, okay, and finally the tip is at the usually near or very close to the hilum of the spleen. It's kind of interesting, and I've never really understood why, but even though the head of the pancreas is so much bigger than the tail, the islets are actually more densely concentrated in the tail than in the head. So go figure that one out. You Google it, and if you find the answer, let me know, because I've never found an explanation. But here, that's basically just the picture we're using to our introduction to pancreas. Another thing we could say by way of introduction and relief is that these are all of the chapters, generally, of Robbins, a couple editions ago. Okay, it covered the entire spectrum of pathology. You may remember we started out with general things like inflammation, hydrodynamics, genetic diseases, tumors, and then we went into the blocks and systems, and we are done with, we'll be done with 6 of the 8 systems, because after today, we've already done kidney, we've already done breast and female and endocrine. So after today, we'll only have skin, bone, nerve, and brain. So we're going to call the skin and bone one the musculoskeletal skin, and then we're going to call the neuro and brain one neuro and central nervous system. And then at the very end, the very last webinar, which looks like it's going to occur in a couple of months now, is going to be done by my son, because he's a world famous retinal surgeon, and he's already prepared a nice video on pathology of the eye. So that's me deserving a rest after having done all of these other blocks and chapters by myself. So in pancreas, I talked to a pathology professor from another medical school, and she made some kind of interesting comments. She said, you know, pancreas shouldn't be too difficult because all you have are pancreatitis and tumors. And actually, she was right. So when we look at our objective for diseases of the pancreas, we're basically going to be looking at etiology, risk factors, morphology, clinical features, outcomes of inflammations and neoplasms. So she was right. When you talk about pathology of the pancreas, you're basically talking about inflammation and neoplasm. And a good place to start, especially when you get into the congenital diseases or malformations, is right here, the foregut. Okay, and you can see in general where a position of the septum transversarium would be, and that pretty much gives rise to the diaphragm, or the separation between the thoracic cavity and the abdominal cavity. The pancreas arises from both the dorsal and ventral parts of the foregut. You're looking here at the ventral part, but there's also a part that arises dorsally as well. Why it arises in 2 places, I don't know. But in the process of doing it, eventually it grows and wraps around and becomes one pancreas. But sometimes you can see evidence that there was really a dual origin. And here's the foregut up here in a broader view, and you could see this whole heart and foregut giving rise to the lungs and most of the upper GI system, okay, is still relatively small at one time relative to the yolk sac. But here we go. We have a ventral bud and we have a dorsal bud. And it looks like the dorsal bud is kind of smaller at first, but the ventral bud, okay, actually includes the entire liver, the gallbladder, the extrahepatic biliary duct system, and something that eventually will become the ampulla of Vater. So the predominant one bud is the ventral bud from this foregut. As it gets bigger and progresses with time, you could actually see the ventral pancreatic bud being separate from the biliary tree and gallbladder, okay? And also notice that this part of the duct, technically there should be 2 pancreatic ducts, one that has arisen from the dorsal bud and one that has arisen from the ventral bud. But the one that has arisen from the ventral bud will send things ultimately back into the duodenum with very, very, very heavy contribution from bile. You know, not just from the liver, but from the gallbladder, which is the big source of bile. Okay, now you're in the duodenum. This is all retroperitoneal, this is all retroperitoneal, and all of this. So you're not going to see this or remnants of it just by opening up an abdomen. You open up an abdomen, you'll never see the pancreas or duodenum because it is retroperitoneal. It's not within the abdominal cavity proper. But here we go. And you can see eventually it swings around a little bit. And this ventral bud then fuses with the dorsal bud. But the ventral bud still sends a duct into the common duct, very, very close to where it opens into the duodenum. Sometimes it's separate, but most of the time it's right before. If you remember in your dissection, you dissected out the common duct. You could see as soon as you cut into it, you could see something. And remember this also. The dorsal bud, okay, technically could still have a separate opening into the duodenum a little bit higher up, but it usually doesn't. Usually the duct from the dorsal bud, okay, called the duct of Santorini, okay, is closed. It atrophies, it just closes off. So all of the, in 90-something% of the time, all of the pancreatic secretions come through ultimately what was once the ventral bud, okay, and ultimately then emptying into the common duct just before the common duct goes into the ampulla. Okay, you should remember that from general anatomy. And here we are now with a dorsal connection, theoretical connection. You can see it's in dotted lines because it usually closes off. Sometimes it's open, a couple percent of the time. But the duct from the dorsal bud is called Santorini. And the duct from the ventral bud is called Wirsung. And Wirsung becomes the predominant duct that opens up into the common duct right before it goes into the ampulla. Very, very simple. And take a look. Even though this is a theoretical model of an embryologic thing, we see that the dorsal and ventral bud form this great curvature which kind of hugs or cuddles into the curvature of the duodenum, which is maintaining that area, maintaining that configuration all the way into adult life. So here we are in an adult, and it's the picture we saw at the beginning. We have A, which is now called the main duct, okay? But we have that accessory duct, what used to be the Santorini duct, and now this main duct, and contributions from the accessory duct usually empty into the common duct. Now, if you've actually tried to dissect this out as a first-year medical student, you probably found it's just impossible, okay? Most of the time when you dissect this out, you have to actually cut in from the duodenum, look for a papilla, and then dissect backwards, okay? So this is a dissection that most human beings, and perhaps even most surgeons, are not really capable of, okay? This is very difficult. Here you have the descending duodenum, the transverse, the ascending one, and that's all basically surrounding the head of the pancreas, with usually one duct, but sometimes two. And here's a posterior view now. You can see the duodenal sweep much better, ultimately ending here as the jejunum. This is something you'll never see, but embedded in this pancreatic head duodenal sweep area, you can actually see the superior mesenteric as well as the celiac vessels, artery and vein, and also the splenic artery joining up with the superior mesenteric, and further down the inferior mesenteric to become the big portal vein too. So this is a very, very, very complex anatomy, okay? And it's much easier to visualize in your mind than try to dissect through it in a routine autopsy or even a surgical procedure. And that's why most surgery that's done on the pancreas, especially the head of the pancreas area, like a Whipple's procedure, it doesn't just include the pancreas, but it basically includes a lot of the things that surround it, okay? A very, very, very delicate operation. Not many surgeons enjoy doing Whipple's procedures. Probably one of the most difficult surgical thing you could do. And also has a very significant morbidity and mortality. Even though carcinoma of the pancreas ultimately would have 100% mortality, a Whipple's procedure itself, which includes surgery of this area, by itself has a sizable mortality. Maybe it's only 10 or 15%, but It's a very, very, very delicate operation. Here's the blood supply. Both the celiac trunk sends branches, the big one being the common hepatic artery, to send branches to the duodenum and the head of the pancreas area. And then you have the superior mesenteric artery, also involved in supplying the middle portion of the pancreas, okay? And then most of the body and tail of the pancreas is fed from branches of the splenic artery, which you remember is also a big major branch of the celiac trunk as well. So this is another good visualization. And as you might guess, this entire organ here, these entire organs, the stomach, the duodenum, the pancreas, the spleen, these are all portal fed organs. So you're going to have the junction of the superior mesenteric vein and the inferior mesenteric vein and the splenic vein ultimately joining together to form the big portal vein. Okay. So that's why cancers of any of this area are more likely to go to the liver, perhaps even before they go to the lymph nodes. And here, let's talk about the lymph nodes as well. I have never memorized these specific regional lymph nodes simply because we never had to. You don't have to do it in pathology. You don't have to do it in surgery. But look, you have certain nodes that are called pancreatosplenic. And as you might guess, they're in this area. And then you have celiac nodes surrounding the celiac trunk. And then you have superior mesenteric nodes surrounding the superior mesenteric. Then you have pyloric nodes in this region and hepatic nodes in the region. So technically, when a Whipple's procedure is done or any surgery is done for carcinoma of the pancreas, everybody is happy if you just call all of these peripancreatic lymph nodes. Okay, but because to tell you the truth, if you find any lymph node in this area, you could probably never be 100% sure whether it's pancreatosplenic or celiac or superior mesenteric or pyloric or hepatic. Okay, so peripancreatic, just to make your life easy. Well, here we go. Here's where it all empties. Here's the ampulla. It's that big papillary projection which you may see in the duodenum. And if you cut through it, you're going to very, very quickly be into the pancreatic duct, okay? The main and usually the only pancreatic duct, but also going up into the common bile duct. Now, we haven't really talked about diseases yet. We're still into basic anatomy, physiology. But take a look at this pancreatic duct, and I'm going to ask you a question. What direction is the juice going into? It's going into the ampulla, isn't it? What direction is the bile going into? It's going into the ampulla, isn't it? So it's important to remember that the flow of both of these ducts are parallel with each other. Because if for some reason there's some type of blockage and the bile goes into the pancreatic duct, that's a major, major cause and a big, big factor in both acute, especially acute, but also chronic pancreatitis. And of course, blockage of any portion of the pancreatic duct, main or branches, could also be a factor in pancreatitis. Here are tiny little fibers that are circular, formerly called the sphincter of Oddi. Now they have been renamed into sphincter of hepatopancreatic ampulla. And the ampulla of Vater now is more often called by the anatomical purists the hepatopancreatic ampulla. And here's what it looks like, perhaps from an EGD point of view. Okay, we're looking in the duodenum, and you can see this nice little bump, and that's all that it looks like. and that's the ampulla of Vater. Or if you'd rather, if you'd like to pronounce long words, you might want to call it the hepatico-pancreatic ampulla. Okay. And here's a nice diagram from an axial slice, which of course has to keep in mind with our CT and MRI findings, but the L2 spine is always very, very easy to find. Just anterior, almost directly anterior to that is the aorta. A little bit off to the right is the inferior vena cava. Both kidneys should be seen very, very nicely, but remember the right kidney is always a little bit lower than the left, so you may see parts of the left but none of the right, or vice versa. And now you have a big shadow from the liver, you can see the spleen, and you'll see stomach and loops of bowels and intestines. Let me show you now what this might look like in reality. Of course, there's your spine, and those are your kidneys. There's the aorta. This is the IVC. Here's the pancreatic head. Here's the body. Here's the tail. Here's the liver. Looks like this is a pretty enlarged gallbladder here, isn't it? But it doesn't have to be. Here's a stomach. You can see there's a nice air bubble. Here's portions of ribs, and that's quickly your frame of reference. Okay, approximately at the L2 level, you're always going to be slicing it to get best views of the pancreas. Same thing, different CT, stomach with the fluid level, couple of kidneys. Now, it doesn't mean this kidney is small and this kidney is large. You're probably just cutting it where one of them dips down a little further than the other. There's your spine. There's your aorta. There's your IVC. There's your pancreas. Looks like this is part of the spleen over here. It has basically the same kind of density as the liver. There's your gallbladder. And there's your splenic blood vessel right along there, always paralleling nicely the pancreas. That's one good frame of reference as well. Diagram of the histology. Of course, we've already dealt extensively with the endocrine pancreas. Okay, I think you can see an islet here. These granules go directly into the blood. Okay. Alpha cells, beta cells, delta cells, blah, blah, blah. But these, of course, connect up to intralobular ducts, going ultimately interlobular ducts, ultimately into the main pancreatic duct. And once again, opening up almost at the same level as the ampulla as the common duct. But here are your actual pancreatic secretion cells, secreting all your digestive enzymes. And the linings of the most proximal ducts, okay, to where the actual secretions are in these acini, okay, are lined by centroacinar cells because they're in the central portion of the acinus. And they make bicarbonate much in the same way to basically neutralize and help in activating these zymogen granules, which are inactive enzymes that get converted into the active enzymes when they're secreted. But this is what it looks like in real life. Nuclei at the base, granules towards the acinar surface. Here's a transmission electron microscope. Here's the nuclei of your pancreatic cells. There's a beautiful one. There's a beautiful one. Here are all the zymogen granules towards the apex of the cell. Here's the lumen. Maybe we have portion of a centroacinar cell over here. And then basically, to make a long story short, you have your intralobular ducts going into your interlobular ducts, ultimately leading into the pancreatic ducts. In real life, again, these are just nice little pancreatic acini. I put a question here probably a couple of years ago, find an intercalated duct. Well, these are the ducts that are probably at the earliest level. So anything that you could see in this cluster of acini that looks like it might have a centroacinar, more of a spindly cell, like here, for example, might be an intercalated duct. But tell you the truth, maybe this one might be too. But I wouldn't bet my life on it. But this looks more like a small duct than an acinus. Another basic physiology. Remember, we have digestion of all the three major food groups: the carbohydrates, the fats, and the proteins. Okay, amylase working on the carbohydrates, okay? Lipase working on the fats. Even direct enzymes for digesting and hydrolyzing both DNA as well as RNA. And then we have what they call the zymogen granules, okay? And these are filled with a couple of enzymes which are really proenzymes, like trypsinogen, chymotrypsinogen, procarboxypeptidase. These are not direct active enzymes, but they get converted into active enzymes after they are secreted and released. Okay? And guess what? I think it would be good to take a break now, because we've gone into basic pancreas anatomy, physiology, histology. So I got some nice and I think better quality music lined up for you today. I used to play the music on a Bluetooth speaker, but I did some experiments and I found out a way to make the music much better quality if I just play them from the internal speaker. So when we come back, we'll actually talk about what I think I was going to talk about from the very beginning, and that's pancreatic diseases. In other words, a few congenital, but chiefly inflammatory diseases and neoplasms. So here we go, folks. Let's give you 3 more songs in about 10 minutes of time.
While we stand aside and freedom. When you ask how I've been here without you, I like to say I've been fine, and I do. But we both know the truth is hard to come by. And if I told the truth, that's not quite true. Some days are time, some days are slow. Sometimes the hard times won't leave me alone. Sometimes the cold wind blows a chill in my bones. Some days are diamond, some days are stone. Now the face that I see in my mirror, more and more is a stranger to me. More and more I can see there's a danger in becoming what I never thought I'd be. Some days are diamond, some days are stone. Sometimes a hard time won't leave me alone.
Ducks and quack and fish go blub and the seal goes ow, ow, ow. But there's one sound that no one knows. What does the fox say? What the fox say? What the fox say? Hacky, hacky, hack, ho. Hacky, hacky, hack, ho. Hacky, hacky, hack, ho. What the fox say? What the fox say? Big blue eyes, pointy nose, chasing mice and digging holes. Tiny paws up the hill. Suddenly you're standing still. Your fur is red, so beautiful, like an angel in disguise. But if you meet a friendly horse, will you communicate by more? How will you speak to that horse? What does the fox say? What the fox say? What the fox say? What the fox say? What does the fox say? The secret of the fox, ancient mystery. Somewhere deep in the woods, I know you're hiding. What is your sound? Will we ever know? Lost in the mystery. Why do you listen?
Well, I'm back, as I threatened to be. And usually when I take this 10-minute break, I only get like a couple of thoughts that I either forgot to say or I want to say. And here's the two thoughts that I got today. First of all, I'm happy today. That's the main thing. But why? They're basically related to these two things. Birds fly south and no betrayal. I got to tell you the first one. You know, most people think that birds fly south. And they often do, especially when you're in an Arctic area like Chicago. But we got birds here in Zion because it's part of a massive state park that I live on that refuse to fly south. There's a lot of places for them to hide, and plus a lot of people feed them too. So we have seagulls and we have geese. And they did not fly south this winter. I feel really sorry for them. So there's one area where they congregate near the park entrance, which is also a massive parking lot for a large shopping center, but it's hardly any cars there. And yesterday I gave a bunch of seagulls, what I usually give them is like 5 bags of Cheetos. They go crazy over it. And it seems like that the geese like the dried corn better than the Cheetos, but the seagulls. So if they're mixed together, you know, the blacks and the whites mix in over here. And I put the Cheetos on one side and the dried corn on the other side. They separate and eat their meals. And yesterday they were very, very, very happy. they just went crazy. I made some movies. They were singing and flying around me, you know, like I just released them all from prison. They just love when people feed them. So that's one reason why I'm really happy. The other reason is I told you several times this month that the webinars would not be 2 hours. And I betrayed you because in each case they were 2 hours. But today I'm happy because I'm not going to be betraying you, because I know with what we have left we could probably do it maybe in 20 minutes or a half hour. So we're gonna you're gonna get a reprieve from the governor today, and you won't have to serve your full sentence. We'll put you on either probation or parole or something like that. So let's close off this guy here, and let's go back to the PowerPoints and finish him off, and you know, quit talking about crazy things. Pancreas diseases: congenital, inflammatory. And even though, you notice how we put the word cyst under inflammatory rather than neoplasm, because technically a cyst is like a bumpy tumor. Most of the cysts of the pancreas are related to inflammatory diseases, mostly chronic pancreatitis, but also acute. Now, the congenital diseases all arise from that nice diagram that I showed you about the embryology of the pancreas. If you remember, we had a dorsal bud and a ventral bud, and they fuse somewhere in the middle of pregnancy. But sometimes they don't. Okay, so sometimes you could actually have two pancreases leading with two ducts into duodenum. That's not terribly uncommon, and very, very often, and most of the time, it's asymptomatic. Now, could you have theoretically a situation where the pancreas never develops? Yeah, there's a couple of genes controlling development of the pancreas, and mutations of these or absence could result in agenesis or complete absence of a pancreas, which, as you might guess, is pretty incompatible with life. You need a pancreas. This is very, very rare. I have never seen it. Could you have, rather than failure of fusion in a pancreas divisum of the two buds, could they basically fuse but also surround the entire duodenum? Yeah, that's called the annular pancreas. So rather than the pancreas just being tucked away within the sweep, ascending and descending transverse parts of duodenum, it actually completely surrounds it. And that would be like a superfusion rather than a failure to fuse. And that's very, very rare also. But the one thing that is extremely common is ectopic pancreas. In fact, you might remember when we talked about esophagus, we talked about stomach, we said that little pancreatic rests, or ectopic pancreas, pancreatic rests, R-E-S-T-S, are very often seen. And very often, it's happened to me several times, where a surgeon goes into an abdomen and he sees these little diddles, these little tiny masses about the size of a piece of rice or a pea at the biggest, and they're studded throughout the bowel. And he says, "What is this, metastatic cancer?" And I take a look at it and say, "No, that's just ectopic normal pancreas." So these are very, very common, okay, and usually incidental, because, you know, they don't secrete pancreatic enzymes into the surrounding tissues. So these are the common congenital abnormalities of the pancreas. There's the dorsal bud, there's the ventral bud, there's where they fuse, and remember, they could fail to fuse, or they could fuse in such a way that they surround the entire duodenum. These are all logical things. Now, pancreatitis. It's, even though you think that acute and chronic inflammation may be part of the same spectrum, and often it is, even with pancreas, but in pancreatitis, they're almost like two different diseases, because acute pancreatitis is very serious. It has a very significant amount of morbidity and mortality, and chronic pancreatitis is often asymptomatic or perhaps mildly symptomatic. So we're going to deal with them like they're two different diseases, okay? Now, in acute pancreatitis, you basically have things that are associated with your pancreatic enzymes digesting all of the tissues around it. Okay, we're talking about autodigestion. That can result in shock. That can result in dissecting through blood vessels. That could result in things like cooking of your own pancreas or digesting your pancreas. It could produce shock. You know, shock is associated with DIC and ARDS. So this has a very serious disease. And it could also result in abscess in the pancreas or around the pancreas. In the process of this extreme pancreatic process, it could build a fibrous wall in or around the pancreas all the way into the lesser sac, which is out-pocketing of the abdominal cavity. So that's why it's called a pseudocyst, because a pseudocyst is a cyst that is not delineated by an epithelial lining. This is strictly a fibrous process. Okay? Of course, it could obstruct a duodenum. Even normally, the pancreas is surrounded by so much duodenum, you would think it might obstruct it. But an inflamed pancreas is very often associated with actual anatomic duodenal obstruction. Now, in this other disease, which you have to think of as separate, it has not have a high morbidity or mortality. In fact, for the most part, it may be totally asymptomatic. But it's still, on the basis of chronic inflammation, could lead into fibrosis. Well, now you have a pseudocyst again, either in or around or perhaps surrounding almost the entire pancreas. It could perhaps even fill up the lesser sac, okay? It could result in the pancreas chronically not being able to function, which means that malabsorption. And of course, if you're not absorbing the things like fats, proteins, carbohydrates, amino acids, the thing that gives you the most clinical symptomatology is the lack of digestion of fats. So they have fat in their stool, or steatorrhea. And steatorrhea is classically described as extremely foul smelling stools, as well as the presence of fat in the stool, which you shouldn't have. The fat should be digested. And the problem is, I've never smelled a stool that wasn't extremely foul smelling. And of course, with the chronic destruction or chronic inability, perhaps chronic inflammation, also have a secondary diabetes because the islets get involved as well. So these are all the basic features of both acute and pancreatitis. But if you want to make it very simple, acute pancreatitis, extremely serious. Chronic pancreatitis, bothersome, but does not have a significant morbidity or mortality. Now, acute pancreatitis has several things it's related to, or we could say risk factors, or we could say even etiologic factors. It goes hand in hand with alcoholism, okay? The classical clinical patient presentation for an acute pancreatitis, the person that goes off on a binge, perhaps the entire weekend, they come back on a Sunday or perhaps Monday morning, extreme abdominal pain, epigastric, substernal, abdominal, because now we have something that is characteristic of most cases of acute pancreatitis, and it's called bile reflux. And if you remember, I told you that both the bile and the pancreatic juice should be flowing in the same direction. And they meet more or less at the ampulla or right before the ampulla. But what happens if the bile, for some reason, edema, tumor, anything, backs up and goes into the pancreas. Well, you put bile in the pancreas and it's going to cause acute pancreatitis. That's as simple as that. Okay, now acute pancreatitis has been linked with some drugs, and thiazides is always at the top of the list. You know, your simple, common, probably most common type of antihypertensive, at least classically. If a patient has an extreme amount of fat or triglycerides in the blood, or an extreme amount of calcium, then this is a factor as well. Of course, if you have ischemia to a pancreas, like you get ischemia to anything, a heart, a kidney, okay, it's going to become damaged and secondarily inflamed acutely. What about somebody that has blunt abdominal trauma, significant, okay, or iatrogenic abdominal trauma from significant surgery in that area? Well, that could also inflame the pancreas as well. And as you know, in the general blunt abdominal trauma, okay, usually the spleen is the number one organ that you're worried about. But even if it's a splenic, general abdominal blunt trauma, even if the kidney or the spleen is basically the organ that is most damaged, you're probably going to have significant elevation of your amylase as well, which means even though you may not see it grossly or microscopically, the pancreas is damaged. Now, there's a couple of genes involved in the development and function and the proper growth and the proper function of the pancreas. And one of them is called PRSS1 and the other is SPINK1. So perhaps mutations or absence of these properly functioning genes are often seen with acute pancreatitis as well. And of course, these are all the factors that we know are associated with acute pancreatitis. But in about, 10 or 20% of the cases, none of these factors are present. So you'd have to call it idiopathic, okay? I wouldn't be surprised if somewhere along the line they actually call that autoimmune pancreatitis, but for the most part, we'll just call it idiopathic now. Patient with acute pancreatitis has usually significant abdominal pain. It may mimic cholecystitis. I can remember actually seeing a patient in which I felt it was acute pancreatitis, but it wound up being cholecystitis, and they could be confusing. But remember, this has an extreme high mortality, morbidity, and this patient has to be seen and taken care of instantly. You just can't give him something and say, but if his amylases, for example, are sky high, 3, 5, 10, 20 times higher than they should be, that's the big thing. Now, the pancreas has a bunch of lipases and nucleases and zymogen enzymes as well. The single biggest one to follow is regular old amylase. So the degree of damage to of the pancreas, acutely or chronically, is directly related often to the elevation of amylase. Well, I don't think I have to say much about this. An acutely inflamed pancreas will be edematous. And why will there be fat necrosis? Well, maybe the lipases are digesting the surrounding fat, and the pancreas is loaded with not only peripancreatic fat, but very often a significant portion of the pancreas itself has a fatty infiltration. You might see an acute inflammatory infiltrate, of course, which means neutrophils. And think about it. You have an organ here now that is releasing enzymes which digest every possible type of food you can eat. Well, that includes pancreas as well. The pancreas digests itself. The walls of the blood vessels are destroyed or digested. And that can produce significant hemorrhage, shock, DIC, all these terrible things we're talking about. Now, there's another word that's used with pancreatitis, especially acute pancreatitis, that's called saponification. And if you're wondering what that is, sapo is basically the same word as soap. So why would an acute pancreatitis produce soap? Well, you know, the regular bar soap that you use is sodium stearate. Okay, the stearate comes from the fat, and the sodium is the salt that makes the soap not only dissolvable, but a great emulsifying agent. And even most of these soaps that you have, and there's 50 different kinds on the market, they're probably still going to have some type of stearate or stearate compound in them. Now, if the fat is digested, your free stearates combine with your sodium to produce sodium stearate. Sodium stearate is soap. Now, if these free stearates combine with calcium, they become calcium stearate. Well, what's the difference between sodium stearate and calcium stearate? Well, sodium stearate is soap. It's dissolvable. It's an emulsifier, okay? Calcium stearate is insoluble, okay? Did you ever have a bathtub ring when you took a bath? Well, what do you think that crud is along the edge of the bathtub? That's calcium stearate. It's your soap dissolving with the calcium that's in the water source, okay? So you might call it soap scum or you call it a bathtub ring, but it's not soluble. So if you now have free stearites being released because your enzymes, your lipases are breaking down your fat, if they combine with sodium, they become soap or saponified. If they combine with calcium, they become calcified. So that's why very, very often, you know, here you see a pancreas here. You can know this is the head, this is the tail. It's very hemorrhagic. If you were to ask somebody, what is this? You might say, well, it looks like a piece of meat that's been partially digested. Or you might say, maybe it looks like something the dog puked up, okay? But what it is, it's a pancreas that has auto-digested itself partially. Now, I know you're probably going to wonder what the microscopic looks like. So I'll show you what the microscopic looks like. And you're saying, why are you showing us such a shitty slide? It's not in focus. You can't see nuclei. It's blurred. Why would Dr. Benarsik show us such a crummy, poor quality histopathologic slide? Well, guess what, folks? This is not something that is blurred. This is something that is digested, okay? The fat is starting to be digested. The acini are starting to be digested. And I do have a picture coming up pretty soon. I'll show you that. But that's the picture of acute pancreatitis. What about chronic pancreatitis? Could it follow acute pancreatitis? Of course it could. Chronic inflammation can follow acute inflammation anywhere. But if for any reason there's been some pancreatic duct obstruction, okay, especially long-standing, if you remember the general principle we've seen with any duct or any vessel or any tube, whether it's microscopic or gross macroscopic, if you block any duct, you're probably going to have not only a possible dilatation of the duct before the obstruction, you know, in the direction of upriver flow, but it can also set up the setting for chronic inflammation as well. Sometimes this occurs in a tropical situation. Sometimes chronic pancreatitis occurs as PRSS or SPINK mutations. But in most of the time, or half the time, we'll just say none of these are documented. But let me tell you something again, because we said it here, and we'll say it again. acute pancreatitis is seen without a doubt most often in alcoholics. Now, another principle is that chronic pancreatitis goes hand in hand with chronic alcoholism. I've seen cases where alcoholics come into the hospital for a whole wide variety of reasons, and none of them may be related to the pancreas, but if they get an abdominal CT, you could see little calcifications, sometimes outlining the outline of the pancreas. The radiologist will tell you this patient was probably a chronic alcoholic. Now here's a picture of a chronically inflamed chronic pancreatitis. You could see kind of like fatty tissue, but you could also see darker, denser, whiter areas like here and here and here, and maybe even a few little tiny 5 or 6 little speckles in here. These are calcifications, okay? And some of them may less likely be saponifications, but remember, the soap is dissolved, so you're much, much more likely to see the calcium because it doesn't dissolve rather than the soap. And look, here's another CT of a patient, let's say, who came in either with symptoms of chronic pancreatitis or perhaps some other reason. Maybe he's just a chronic alcoholic that came in because of maybe he fell. They do an abdomen CT, and look, here's the kidneys, here's the spine, here's the liver, here's the spleen, and right here where the pancreas should be, it's just stippled with some dense material that's probably just as dense and bright as the bone or the ribs. These are calcifications outlining the entire shape and anatomic extent of the pancreas. Isn't that neat? Another feature besides calcification and maybe saponification is fibrosis. There is very, very often a very whopping or florid or whopping fibrosis in association with chronic pancreatitis. So let me ask you a question. Let's say we took any one of these areas in here or here or here, and I said to you, is this fibrosis from chronic pancreatitis, because fibrosis follows chronic inflammation, or is this pancreatic carcinoma? Well, most pathologists would have to look at it really hard, and it might not be an easy diagnosis, but the amount of fibrosis associated with chronic pancreatitis can very, very, very often look like these little glands are infiltrating the stroma around it. They call this process scirrhus. Like, for example, a breast carcinoma is often called scirrhus because scirrhus is the root word for scar. So whenever a carcinoma, or in this case an adenocarcinoma like in breast or pancreas, generates a lot of fibrous tissue or invades a lot of fibrous tissue, they might call that scirrhus. But in this case, overall, this is simply chronic fibrotic pancreatitis. And you'll have to take my word for it, because if I even showed experienced people the glands at this power, they would not make up their mind. And I got another little story to tell you, because, we're near the end. I know of at least 2 cases where people came in with pancreatic symptoms and the radiologist or surgeon did a needle biopsy. And if you do a needle biopsy of this area, it might look like adenocarcinoma. And it was called adenocarcinoma. And so the patient had a Whipple's procedure, which is a very, very high-risk procedure, probably has about a 10 or 20% mortality just from the surgery. And then the next day when the whole pancreas came out, plus half of the guy's guts, maybe the spleen, the duodenum, the lymph nodes, they found out it wasn't cancer. Could you imagine the type of lawsuit that was involved? And, both of these people lost tremendous amounts of money, or at least their insurance companies did. Here's a pancreatic duct that is plugged with mucin or inspissated material, okay? Like you might see in cystic fibrosis. When you hear the congenital childhood disease cystic fibrosis, the primary organ that is involved besides the lung is the pancreas. So look, this is plugged, and now you have a lot of inflammation and especially fibrosis within the pancreas. And that's why it's called cystic, because the ducts are cystically dilated, and that's why it's fibrosis, is because secondary to the obstructed duct, you have the inflammation, and secondary to the inflammation, you have the fibrosis. So this is another picture of chronic fibrotic pancreatitis. Now, in chronic pancreatitis, very often it's asymptomatic, like we mentioned, in alcoholics. It could be abdominal pain, but it's usually not as severe as acute. And the abdominal symptoms may not be easily localized or classical. So it's basically kind of a fuzzy clinical diagnosis. And very often, and I made the mistake myself once, confused it with cholecystitis. We said, however, that if you do CT, there could very easily be calcifications. The amylase will be elevated, even maybe not as high as acute pancreatitis, and the patient will not only perhaps have chronic diarrhea because of malabsorption, because of misfunction or inability of the pancreas to produce the amount of enzymes that it should, but you could have pancreatic insufficiency, even diabetes, and all of that fibrosis we saw can produce something called pseudocysts. Now, technically, a pseudocyst is any cystic structure that is not lined by an epithelial lining. However, in most cases of medical literature and medicine, when they talk about pseudocysts, they're most often referring to the pancreas. Here's a pancreas, a lot of chronic inflammation, just studded with all these inflammatory cells. But it produced a fibrosis which resulted in a portion of the pancreas, perhaps only a couple centimeters wide, as being a cyst. So you can imagine this is probably filled with some kind of fluid. However, if you remember that the lesser sac is a very, very large anatomic sac connecting to the abdominal cavity, in which the pancreas has intimate relationship with. In this case, the entire lesser sac is a cyst, and it doesn't have its routine opening into the abdominal cavity. There's the spleen, there's the entire lesser sac, and there's portions of the pancreas, okay? So you could have a little pseudocyst or a pseudocyst that fills the entire lesser sac. Now, last topic, neoplasms. This is not a totally precise, separate list of types of neoplasms, but like the pancreas being a gland, will have primarily adenomatous type tumors. They could be lined by serous cells, basically secreting water, or larger mucinous cells secreting mucus. They could be cystic. They could be even microcystic. So a pancreas benign neoplasm might be called a microcystic adenoma. The glands can have a papillary or finger-like configuration. And up until this, everything we talked about is benign. However, these same glandular type tumors, true neoplasms, could be malignant glandular formations called adenocarcinoma of the pancreas. That's why most of the time when you hear the word cancer of the pancreas, it's adenocarcinoma. And remember, it could have dense sclerosis is generally the rule. In fact, the amount of dense sclerosis that you have with adenocarcinoma of the pancreas could even look better than the sclerosis you get with chronic pancreatitis. So here's something called a serous cystadenoma. And you can see we have some pretty nice, well-defined cystic structures. The epithelium is pretty flat. Maybe I could pop this open for you. I don't know. Let's see. Whoops. Let's see if we could pop it open. Not too much. Here it is grossly, the tiny cysts. They're only about 1 millimeter. Here it is microscopically, flat cells. Serous cystadenoma. You might want to call it a microcystic adenoma because these glands are pretty small. Up here grossly, you can see they're only about 1 millimeter or so. Let's see, there we go. Here's one that's mucinous, and not surprisingly, these little cystic spaces are filled with mucin. And the cells, look how nice and orderly they are. They're mucinous cells. They have the nuclei right at the base. They're lined up like nice little well-behaved children going to school, standing in line. So this is a benign glandular tumor or cystadenoma, and these cells secrete mucus. And they can also form a papillary type of configuration as well, like any glandular tumor could do. We've seen them in the breast, we've seen them in lung, we've seen them in the colon, we've seen them in the stomach. Okay, thyroid, probably most likely ovary, we saw. This is an intraductal papillary mucinous neoplasm. Well, why isn't it called benign or malignant? Why is it just called neoplasm? Well, because we don't know. We don't know if this is going to be invasive. We don't know if it's going to grow any further. And even if it doesn't grow any further, what would you call it if it obstructed the common duct? Okay? Most tumors of the ampulla, benign or malignant, and especially the malignant ones, may be called adenocarcinoma of the head of the pancreas. And why is that? Because the head of the pancreas basically surrounds the ampulla, from outside the duodenal point of view. So there's a papillary mucinous tumor, no big deal. I love this slide the most. And we've seen slides like this before. We talked about developing cancers in other areas. And this is the first one that actually kind of inspires me, because if you look at a normal glandular mucosa, or acinus, you see normal cells maybe become a little hyperplastic. Maybe they become proliferating more. Maybe become atypical, and maybe they invade. So you could call this whole spectrum from normal to here probably dysplasia, maybe carcinoma in situ, but now we have invasive carcinoma. But what are these little things that are labeled from these various stages? So just as you see these stages of dysplasia preceding an invasive carcinoma of the pancreas, you basically see names of genes that are being mutated, like KRAS, P16, P53, SMAD, BRCA2, PANN3, PANN2, PANN1A and B. So the thing that is the most spectacular from my and hopefully your understanding is that in the development from a normal tissue into an invasive carcinoma, you have a sequence of generally linear, but not exactly linear, genetic mutations. Perhaps the earliest stage would be a PANN1A mutation. Maybe in the earliest stages you have telomere shortening. So that means the number of multiplications of a cell is no longer limited. Then you might have a mutation of the P16 protective gene or the P53 protective gene. Okay, so just remember one thing. What pathologists and microscopes have always seen as a developing cancer can now actually correspond in a quasi-linear fashion to specific mutations of growth control genes. And that's what cancer is, isn't it? It's a mutation of growth control genes. Here's a nice picture of carcinoma of the head of the pancreas. You can see it's whiter than the body and tail because there's more fibrous tissue. It may have resulted in perhaps a complete obstruction of the common duct, not just the pancreatic duct, perhaps metastatic, of which the liver would be the first place to go because this entire organ is fed by the portal blood system. And here's another one microscopically where you can see these linear and quasi-oval clusters of glands very intimately invading the fibrous tissue around them, and perhaps even evoking a fibrous response, or what we call a scarous malignancy. These darker things are epithelial cells. That's a cluster of them. That's a cluster. That's a cluster. There's a cluster gland. There's one. There's one. And the rest of this lighter pink stuff is fibrous tissue. And here it is grossly, and all you could say is that it seems to be a little bit whiter in certain areas, and it seems to be very poorly delineated from the surrounding fat. Okay. Finally, our last slide of the GI series and our last slide of pancreas is a tip which I hope that you never forget. When you have an older patient coming into your office and he says, "Doc, you know, I noticed that I'm a little jaundiced lately." Okay. And there's no pain, but, you know, he's worried. Painless jaundice in an elderly person, you know, they don't have to be 100, they could be 50, 60, 70, okay? Painless jaundice in an elderly person must be treated as a possible carcinoma of the head of the pancreas until proven otherwise. So do your workup, do your test, do your CT, do your amylases, do everything. That's probably the most important tip I could give you with respect to pancreatic disease, because they can spread rapidly to the lymph nodes and the liver being, of course, the big lymph node of all the portal drained organs. Why the L2 spine? Because that's the part of the spine that's the closest to the pancreas. And even though, in general, it's more likely for any malignancy to go to the lungs before it goes to the liver, because this is a portal organ, it's very often in the liver before it goes to the lungs. So, you know, you could have a grading system of whether it's well or moderately or poorly differentiated. That's helpful prognosis, but the most important thing is the staging, is to see what the extent is of the biologic behavior of this tumor, or using the TNM classification. Okay, we're done. And I told you we would be done early, and I kept my promise. It's only been 1 hour and 40 minutes. It hasn't been the whole 2 hours. So I feel really good about that. And that means we could probably play our final song, which I believe is going to be this one. It's a very inspirational song by one of my favorite groups, ABBA. It should be also your song as well.
If you see the wonder of a fairy tale, you can take the future
Rock on, buzzards. But there was something very, very important in what Abba just told you, because you're young, is you can have the future even if you fail. So, rock on.